Thank you so much for joining us today for Rogers Behavioral Health Spring Webinar. My name is Genevieve Frazier. Joining me today are two of our clinical leaders, Dr. Nicole Stetler and Dr. Michelle Maloney, and they will be discussing the assessment and interventions for co-occurring substance use and eating disorders. Before we get started, I'd like to give a shout out to our professionals joining at our 3 watch parties in our Wisconsin locations. And here is a quick overview of today's format. Our program will last 90 minutes, and we will be giving a 70 to 75-minute presentation. In order to receive CE credits, you must be logged in for the duration of the 90-minute presentation today. Your attendance will be tracked via the login records and logout records on Zoom. A PDF of the PowerPoint, as well as a full list of references, will be available to you on your personal dashboard at ce-go.com. A recording of this webinar will also be available in the next couple of days on Rogers' YouTube channel, as well as through the resources section of our website. Again, our speakers will give a 70 to 75-minute presentation today. Thereafter, I will facilitate a Q&A session. To submit a question, please use the Q&A button on the bottom of your Zoom taskbar. Note that I may combine questions if there are similar questions presented. Finally, we have enabled closed captioning for this program. Now I'll turn it over to our presenters.
Thank you, Genevieve. Hello, everyone. We have a couple of housekeeping slides to go over through before we jump into our content for today. So these are our disclosures on behalf of both Dr. Maloney and myself. A reminder of our learning objectives and what our plan for what we're going to cover today and what we're hoping you take away from our presentation. And we are going to be covering sort of 4 sections of our presentation today, kind of starting with going over some of the presentations and common ways that symptoms can co-occur, talking more in depth about assessment of both eating disorder and substance use disorder behaviors, and then talking a little bit about how you might adapt evidence-based interventions for addressing co-occurring symptoms, and then closing off with a few minutes spent on some emerging or more controversial topics in the field. Here are some information about us and our presenter subjectivities that we bring with us into this presentation today. All right, and with that, we're going to jump right into our first section, talking about some co-occurring presentations when it comes to eating and substance use. So on this slide here, we wanted to really show how prevalent this co-occurring presentations can be. So the pictures on the left-hand side is depicting that of individuals with eating disorders, research suggests that up to 50% of that group also use alcohol or drugs, which is about 5 times greater than risk in the general population. On the flip side, among individuals with alcohol or drug dependence, up to 35% also have an eating disorder, which is 11 times what we would see in the general population. So what this tells me is that if you are a clinician here who works with patients with eating disorders or a clinician who works with patients with substance use disorders, then you are very likely working with people who have a very high risk of symptoms of the other set of disorders. And now, while there are many, many ways that eating and substance use disorders may overlap, we wanted to spend the first part of our talk today highlighting a couple of different presentations that are of interest and may show up in your clinical practice, and go into those in a little bit deeper detail. Next slide.
All right, and with that, we're going to go ahead and we're going to start with stimulants and looking at an overview of stimulants. Stimulants in general, it is a psychoactive substance that really provides temporary improvement in physical or mental functioning. In practice, occasional users of stimulants tend to start off with experimentation. And so as we think about maybe students who are studying for final exams, college students as we begin to approach the end of the semester, maybe studying for exams, truck drivers who maybe drive long hauls, employees who need to hit a deadline, they may use a stimulant to stay awake, hit a deadline, be able to function. However, that is very temporary. And as part of that temporary, it elevates their mood, increases feelings of well-being, energy, and alertness. After that occasional use, in some areas of the country, stimulants have been considered the second epidemic in addition to opioids, particularly since the COVID epidemic, right? During the COVID epidemic, we saw an impact on what types of substances were being used, mainly due to some supply and demand. And since this time, we have seen a dramatic increase in the use of stimulants. Some things to also know about stimulants: they are some of the most addictive substances known. And currently, there are no real recovery medications as there are for opioids for stimulant use disorder. So here are some types of stimulants, anywhere from things you may be more familiar with: cocaine, amphetamines, methamphetamines. And again, depending on what area of the country you're in, you may see more of an increase in one over the other. As we look at some effects, again, effects between stimulants can differ based on that specific stimulant. However, there are many commonalities. Some of those effects can include euphoria changing depression, hallucinations, sweating, an increase in blood pressure. And particularly where we're focused on today is really that weight loss, loss of appetite, which is what makes stimulants many times prone to individuals with eating disorders.
Exactly. And so as Dr. Maloney was just saying, this is where, as someone who specializes in eating disorders, I get particularly concerned or interested in how this might affect people that I might be working with often. So we know a little bit from the literature. There has been some research specifically looking at folks with anorexia nervosa, so more in the restrictive eating disorder spectrum of those diagnoses, and seeing pretty high prevalence of use of certainly caffeine, tobacco, or nicotine, as well as prescription stimulant medications, and then a little bit less prevalent of use as what we might expect, given that these are more difficult substances to obtain, but also some use of amphetamines and cocaine. Next slide. So when we think about the impact on eating disorders, I think there's certainly a lot of concern and risk that stimulant medications, given the impact on appetite and the propensity for weight loss, might be used as an intentional weight control strategy for some individuals. There's some evidence that this motivation is maybe gender specific, in that women tend to report more often using stimulant medications to try to control their weight or shape than men do. Even if it's not intentional to control weight, I think there's also ways that I would be clinically concerned just for the negative impact on eating development and risk of an eating disorder, or on eating disorder treatment outcomes. So if someone is in treatment for an eating disorder, but they are also using stimulant medications or stimulant substances with those effects, one thing that we're often trying to work on is moving towards a goal of regularized eating patterns. So eating, kind of consistent meals and snacks throughout the day, to kind of also be able to normalize hunger and fullness cues. Now, if someone is using stimulant medications or stimulant substances that may be impacting their appetite, that's probably going to undermine some of those goals of treatment and make some of the processes that we're trying to move towards a little bit more difficult to achieve. So our next presentation that we wanted to talk about is something that is often referred to as drunkorexia, which we will talk a little bit more about what that means and why it is called that. I actually want to start with a little bit of a vignette just to kind of paint a picture of what this might look like, this kind of co-occurrence of alcohol use in combination with disordered eating. So let's think about a recent female patient, Jane, 21 years old, entered treatment due to a recent DUI and dropping out of college. And while completing her assessment, identified that she dieted throughout her life, as all of her friends did, and indicated that she would not eat all day in an effort to save calories for alcohol consumption when she would go out at night. She indicated that she didn't think she had a drinking problem, as she would only drink on the weekends. I did acknowledge that she would start drinking until she blacked out. She stated that she would exercise a lot during the week due to the number of calories she consumed from alcohol, so in an attempt to kind of compensate for those. So this kind of paints a picture of what drunkorexia, or this combination of alcohol use and disordered eating, can look like. When we're thinking about what it is not a clinically recognized term or diagnosis, but it is this pattern of behaviors that has been identified and looked at in research and certainly seen clinically, where we see some combination of restriction of caloric intake, excessive physical exercise, and alcohol-related use disorder. Estimated to affect a pretty wide proportion of people, and I think especially prevalent among women, among younger people between 10 and 19 years old, and also among Caucasian individuals. So some common behaviors that we might see within drunkorexia, and some of these were highlighted in the vignette that I talked through, but restricting food to control weight, so kind of classic restrictive eating behaviors. Exercising, but specifically exercising to compensate for the calories consumed from drinking. Now, that could be before the drinking occurs, sort of to preemptively burn off those calories in order to prepare for drinking later, or it could be after the drinking occurs. Using stimulants or laxatives or diuretics to control weight, so other kinds of compensatory behaviors that we might see as part of this. Similarly, inducing vomiting during or after drinking, which might be also a part of a weight control strategy to kind of purge and eliminate those calories. Drinking large amounts with the intention of vomiting, or restricting calories before or during alcohol use to intensify intoxication. So the idea that if I don't eat very much, or if I don't eat while I am drinking, then I'm going to feel the effects of that alcohol, feel drunker, more intoxicated more quickly or more intensely.
And as Dr. Stetler mentioned, this is not a current diagnosable, right? It's not in the DSM-5. And part of it is, there's not a lot of published research currently available on drunkorexia. We did find research that was published as late as 2024. And so we are starting to see more research. But we really want to, see more research come out about this. Some of the research we did find found that there was an impact from, COVID. And I think we're going to be saying that, for probably years to come as we try to figure out, the true impact of COVID-19 and the pandemic. But during that time, younger individuals reported higher scores for both drunkorexia behaviors and alcohol use disorder. Some of this may be because there were companies that would deliver alcohol to your home, right? You could order it and it would be delivered. Some of the open container laws were relaxed during COVID-19. And so there could be a lot of social reasons for this impact with alcohol. And again, as mentioned previously, supply and demand regarding substance use disorder changed during the pandemic. And so alcohol became much more readily available. The research also found that men were more likely to drink alcohol than women, particularly related to the pandemic-related stress, which could have contributed to increased alcohol consumption. We also saw that isolation tended to impact, particularly more women than men, as it related to the use of alcohol. And as we look at assessment and evaluation regarding drunk anorexia, truly looking at the alcohol use, including the patterns and the amounts, because we may need to look at detox. How do we stabilize an individual? Are they underweight? And so we need to take that into consideration as detox protocols are examined. During the assessment process and evaluation, also looking at some risk factors that were found in the research, including body dissatisfaction, difficulty in emotional regulation, low self-esteem, possibly some genetic predisposition, although again, more research is needed in that area. But the inability to manage stress was one of the most significant relevant factors that we found across the research, particularly as it combined with anxiety and post-traumatic stress disorder. And so as we look at treatment, really a key here, and you'll probably hear us say this several times throughout this presentation, is a multidisciplinary team is critical, right? Individuals who specialize in both substance use disorder, eating disorder, having a medical team, nursing team, really that multidisciplinary approach. And then a comprehensive approach targeting that emotion dysregulation, particularly, in teaching skills to manage and tolerate emotions. Impulsivity tends to be a factor, right? And including family therapy and community support. Who can they go to seek support from, whether that's a community support group, whether that's, social groups, therapists, peer support, and so they can get encouragement throughout the process.
All right. As the last part of this section, we wanted to highlight one more overlapping presentation talking about substance use and binge eating. So I think clinically, we often hear from patients that when it comes to engaging in binge eating, feeling out of control with food intake, oftentimes people can attribute that to use of substances. So, I was drinking or I was high or something like that. And then I happened to engage in binge eating at the same time. There's sort of this hypothesis about disinhibition. So that the substances lead to a level of disinhibition and make it more difficult or more likely that a loss of control event around eating would happen. Now, sort of interestingly, this isn't really well supported by the research. So research that's looked longitudinally or done EMA studies where they've kind of asked people to track their behaviors at random times throughout the days and weeks, haven't really found this strong connection or link between substance use predicting binge eating, even for substances that we know have appetite stimulating effects like cannabis. So maybe some suggestion that this is sort of a post hoc explanation, or I think another hypothesis is that it might be related to expectancies. So there is one study at least that showed that cannabis users who have eating disorder symptoms present as well do report expecting their cannabis use to increase their binge eating behavior. So perhaps having some of those thoughts and expectancies going into that use time may lead to those behaviors being a little bit more likely or risky. I think where the evidence is a little bit more compelling is that actually when we're considering substance use and binge eating, what we may be really seeing is some shared vulnerabilities or mechanisms that lead to or increase risk for both of those sets of symptoms to be present. So some underlying vulnerabilities that seem present both for substance use disorders and binge eating behaviors include impulsive personality traits, being in negative mood states, and having positive expectancies. So again, kind of thinking that use or that binge eating is going to come with some kind of benefit to them, usually that it's going to provide some relief or reduce negative mood or produce a sense of euphoria, something like that. I think one of the other shared vulnerabilities that has been identified is impairments in executive functioning, particularly maybe around set shifting or decision making. And I think one of the other kind of pieces of information or evidence for this is that lisdexamfetamine or Vyvanse is an FDA-approved stimulant medication for the treatment of moderate to severe binge eating disorders. And it seems to work by altering some of those neural networks that are associated with things like executive functioning. So again, kind of some accumulating evidence to support that perhaps where we see these symptoms co-occur might be due to underlying shared risk factors.
And so this is a graphic of some of the things that our patients typically experience, right? So a typical cycle of entering substance use treatment, you know, once someone has gone through potentially detox, cravings are a natural part of substance use and substance use treatment, right? And so, you know, our bodies are used to processing many of these substances as sugar, right? Our liver is looking at processing the sugar. And so our bodies may not recognize that that's what's going on. And so what we typically see in some of our treatment programs is that particularly, you know, individuals who started drinking, let's say at 5 p.m. when they got done working, they might be eating a lot more sugary foods at that time, right? And almost compensating for that craving. And then what we see is then individuals start to gain some weight, particularly in residential programs. You know, they talk about the residential 15. And so when we look at the treatment of substance use and eating disorders, it is imperative that we are pre-positioning this with our patients so that we can have these conversations and addressing potential, you know, weight gain as a relapse trigger. And incorporate this really into that individual's treatment plan, recovery maintenance plan, because as they gain weight, if we're not addressing some of these, then we might see the patient relapse, and then they enter treatment, and then, you know, the vicious cycle continues to go round and round and round. And so again, very critical in addressing both of these within the treatment plan and recovery maintenance plan.
All right, perfect. So we're going to move into the second section of our talk today, focusing more on how do we assess these things. If you're someone who specializes in eating disorders or someone who specializes in substance use, you may or may not know what questions to even ask or how to screen or assess for these things among your patients. So we're hoping to give you some tools related to that moving forward. Starting off with some validated screening and assessment tools for eating disorders. There's a few that I wanted to highlight. These are all ones that are easily available, included some links on these slides as well when available, but you could also search for them pretty readily, find them. The first one, the SCOFF, is something that it's a short 5 questions. It's used a lot as a screener in kind of primary care settings and other healthcare settings. I think one of the big limitations with the SCOFF is that it is most sensitive to symptoms of anorexia and bulimia, and particularly among young women. So it may not be as sensitive to other eating disorder behaviors or as sensitive to those presentations in kind of the less traditional historically demographics. So there's some real limitations of it, but it is widely available. It is often used, and it is part of a screening, brief intervention, and referral process that you can read more about at eatingdisorderscreener.org. The EDQ is the next one that I put on here. This is a longer questionnaire, maybe like 40 questions or so. It is a self-report measure. It is more sensitive to symptoms of kind of across the eating disorder spectrum, with the caveat that it doesn't really touch on ARFID very much. It has been used as an assessment tool and kind of a gold standard one that is often used both for identification, but also for monitoring symptom progress during treatment, and is freely available. So that could be one potential option But again, if you're also wanting to screen for ARFID, I would also recommend coupling that with the 9-item ARFID screen, the NIAS. There's limited validation for this screener so far, but then the benefits are that it is short and it is specific to ARFID. So when used in conjunction with the EDUQ, you get a pretty good screening across a lot of different kinds of eating disorder behaviors and symptoms that might be coming up. The other piece of assessment with eating disorders that's really critical is getting medical information, because eating disorders can have such an impact on the body and physical health. And this really becomes really important, as we'll talk about later, for when we're going into treatment recommendations as well. So this is a list of snapshot of many of the different pieces of medical information that we're often looking for as part of assessment. And if you are a clinician practicing in the community who is not going to be gathering this information, it's outside your scope of practice, you might be collaborating with someone like a primary care physician or another healthcare provider. And oftentimes those folks are not necessarily specialists in eating disorders. So I did want to highlight one resource from the Academy for Eating Disorders. That's the cover is over on the slide there. And this is a really nice guide that gives even kind of people that maybe don't work with eating disorders all the time, some really clear guidelines about how to do some screening and assessment of medical care. So this can be a helpful resource if you're trying to partner with those other healthcare providers that are part of your patient's team, to be able to make sure that you all have as much information, both about the behaviors and symptoms, but also about medical stability to help inform a treatment plan.
All right, and for substance use disorders, so if you specialize in eating disorders and don't know a lot about substance use disorders, all of these assessment tools are available on the public domain. And you can get a lot of these through the NIDA website. And the NIDA website does provide a lot of good resources, and they even have a chart of tools that you can access and utilize. And given that April is Alcohol Awareness Month, I thought I would start with the audit. And the audit, or Alcohol Use Disorders Identification Test, is a widely used screening tool. It's designed to identify individuals with, potentially harmful patterns of alcohol consumption. And it was developed by the World Health Organization. It consists of 10 questions that cover 3 domains, including consumption, drinking behavior, and then alcohol-related problems. And one of the things that we really need to talk about more, and we're going to do that on the next slide, is what is a standard drink, right? Because it'll say, or maybe even when you've gone to your primary care physician, they will ask you about how many drinks you've had each week, right? And so it all depends on how you measure a drink, and we've seen individuals measure their drinks very differently. And so we'll get a little more into that. The second one is the DAST, or the Drug Abuse Screening Test. So the first one is related specifically to alcohol, and this one is other substances. And this is, again, a self-report instrument designed to screen for substance use related problems. And the most commonly used version of this is the DAST-10, which consists of 10 yes or no questions that assess the frequency and impact of substance use on the individual's life and health. It's widely used due to its simplicity and ease of administration. It can be used in various clinical settings. Now, the third one is an adolescent screening tool, because we do tend to see adolescents with both substance use and eating disorder. And this one was developed to be sensitive to adolescents and to identify alcohol use among adolescents. And this was really developed in collaboration with the American Academy of Pediatrics. And it consists of a 2-item screener that assesses both the adolescents' own alcohol use and their peers' alcohol use over the past year. So this really is a screener that then will allow you to go much more in depth. And one of those tools that you can utilize to go in depth is called the CRAFT. And the CRAFT is a validated substance use screening for adolescents age 12 to 21. So it goes a little bit beyond adolescence, but it's highly recommended by the American Academy of Pediatrics in their Bright Futures guidelines for preventative care. Again, it's brief, it's validated and designed for adolescents, and it consists of 6 yes or no questions for the adolescent to answer. As mentioned, this is a standard drink guide, right? So one drink is 1 12-ounce can of beer, or a 5-ounce glass of wine, or a 1.5-ounce shot of liquor, right? And so, some individuals may fill their drinking glass with their water glass with wine, right? That would potentially be considered 2 to 3 and not just one drink. So it's important to also identify, what is a standard drink for that consistency. And this is again, a standard drink card that you can utilize. It also gives you, low risk drinking limits. Again, that will be based on each individual, as well as a readiness ruler to work with individuals to see, are they willing to, how willing are they to stop their drinking or cut down on their drinking. And so as we're thinking, now what, right? So given that clinical judgment and case conceptualization, right, that's really where we want to focus here. Because none of these tools are going to look for both. None of these assessment tools, it's not going to be a one size fits all. And so again, clinical judgment, case conceptualization becomes the key to integrated treatment. And Nicole is going to talk about that over the next couple of slides.
Perfect. So exactly as Dr. Maloney mentioned, because we don't have a clear, if eating disorder symptoms and substance use behaviors are presenting together, we don't have a clear treatment manual out there this is the gold standard approach to addressing these symptoms. So we want to guide our clinical judgment by really having a good case conceptualization to help us identify a treatment plan for the patients that we're working with after we've screened and assessed for risk. So there's many different ways to do case conceptualization. I'm not saying that this is the one right and true way, but I think that there's some key parts in particular that we really want to pay attention to when thinking about how this is going to be used to help drive our treatment plan. So one thing that we really want to make sure we're getting a good sense of is, what are the symptoms and problems going on? So we want to understand the type, frequency, and quantity of substance use. We want to understand the type, frequency, and severity of eating disorder behaviors. We want to get some of those medical markers that I mentioned earlier, including something like current height, weight history, growth, things like that. To help guide our conceptualization, we want to consider predisposing, precipitating, and perpetuating factors. And these could be for one set of symptoms, for all sets of symptoms, but this will kind of help us start to identify what might be, for example, risk factors or vulnerability factors that might underlie both maybe substance use and eating disorder behavior, sort of like we talked about earlier with substance use and binge eating. Precipitating factors, so those factors that contributed to symptom onset. And then we also want to really be thinking and even kind of going more into depth about perpetuating or maintaining factors. So what are the things that are going on that we hypothesize are maintaining those behaviors or symptoms for the patient? Oftentimes doing a functional analysis of those symptoms can be really helpful. So considering what is substance use or eating disorder behaviors doing for that individual? Is it helping them cope with negative emotions? Is it helping them reduce anxiety? Is it providing a pathway for seeking pleasure or getting those kind of pleasant experiences or sensation seeking? Those would all help us kind of understand a little bit more what might be maintaining those symptoms. And then because we are talking about comorbidities, we really want to think about the relationship between those symptoms. So considering something like the timeline of onset, what came first, what came next, how are these symptoms functionally related to each other over time? Does one seem to be a common precipitant of the other, or do they seem pretty unrelated or both related to some of those precipitating or perpetuating factors? We also always want to consider strengths and resilience factors, as well as sociocultural context. So considering things like family dynamics, peer influences, cultural attitudes, those things can have a tremendous effect on the development and maintenance of both substance use and eating disorder symptoms. So really making sure that we're taking that into account as well.
All right. So I'm going to take a few minutes and read a majority of this slide, which I normally would not do. However, Nicole and I are going to rely on this case example as we walk through some of the interventions. So we think it's important to walk through this case. So we have Terry, who is a 31-year-old male who presented to treatment with a history of restrictive eating and significant alcohol use since his adolescence. He reported consuming only 1 meal per day, followed by 10 to 20 standard alcoholic drinks. He was restricting eating as a way to look more slim or toned. He stated that this occurred starting at age 17 and continued for about 7 years. This pattern led to inadequate nutritional intake, significant alcohol use disorder. He then entered treatment for alcohol use. After completing treatment, he remained in recovery for about 2 years, although his eating patterns remained fairly chaotic during those 2 years. For the past 4 years, he has restricted during the day and binge eats at night. He denies significant body dissatisfaction, but reports often feeling nauseous and not very hungry during the day. He has continued with his alcohol use and reports that his binge eating is tied to his nightly edible use of up to about 100 milligrams nightly. And in the side there, you can see our addressing model, right? The age being 31, his diagnoses, alcohol use disorder, cannabis use disorder, binge eating disorder, and major depressive disorder. And you can read the rest of the addressing. And again, we'll be using this case throughout. So when Terry entered treatment, we completed a thorough biopsychosocial to gain insight into any medical concerns, right? So had a history in physical, working with, primary care physicians, working with psychiatrists, right? A thorough psych evaluation, examined withdrawal potential, the psychological factors that were contributing, what were his support systems, and what was his motivation, right? And so as part of his assessment, we examined how was he able to maintain his recovery from alcohol for 2 years? What did he believe were his successes contributing to that recovery? What was that progress he made? And what were the challenges during that time, right? And really looked at mapping those, that information for him, really looking at his resilience, right? What was going on in those 2 years, as Nicole mentioned in that case conceptualization, right? What were some of those strengths? What were some of those resiliencies? What were some of those socio-cultural factors that were playing in during those 2 years? And we looked at substance use history, the audit, and he scored a 17 on his audit, which indicated a high likelihood for withdrawal and indicating the need for detox treatment. Um, he also indicated during his assessment that he had lost his job during the pandemic and became much more isolative and felt as though all of his previous progress had evaporated, and he began to have more and more depression episodes, which then led to him socializing with some peers who then introduced him to cannabis edibles, which then he contributed to his binge eating. And so looking at all of that, his nutritional status, getting some of those metabolical panels as part of the assessment process.
So if we take all this information and try to put it together into that case conceptualization that we just talked about, this is by no means exhaustive, but I think might represent some of the ways that we could think about Terry's symptoms and how they might fit together. So we could consider that there's some predisposing social context, right? If Terry disclosed that it's pretty typical among his family and peers to be concerned about weight and engaging in dieting practices, something that he had kind of seen and witnessed very early on in life. Some precipitating factors that prompted the initial onset of symptoms, the initial restriction or dieting and alcohol use really seem to be precipitated by attempts to fit in with peers as an older adolescent. And then what we're currently seeing is some of the same patterns continuing to maintain symptoms. So alcohol and edible use, pretty typical among peers. They introduced him to some of these things. It's something that's kind of normalized. We might start conceptualizing that alcohol use, edibles, binge eating, all of these things are kind of functioning to maybe soothe or numb painful emotions, some of the depression that he'd mentioned, maybe also pass the time. There could just be kind of feelings of boredom, loneliness, and lack of meaning in life that are contributing here that we might want to then address in treatment. There's probably been some learned associations over time. He's kind of reporting this history of nighttime being a particular time of risk, being alone in his bedroom or being with his peer group. Those are all kind of conditions that are associated with use of alcohol or with binge eating. So understanding those learned associations and being able to develop some strategies to manage those urges that are likely to come up in those circumstances is going to be important for treatment as well. This pattern that he's developed of restricting during the day and then eating or binge eating at night would really point to understanding there being some physiological pressure to eat because he's skipping meals, and that is obviously going to make the body concerned and wanting some food. So that is going to kind of set up this cycle of binge eating and then some restriction during the day. And then all these behaviors are leading to feelings of guilt and shame and hopelessness that are then just going to exacerbate his depression and kind of create a cycle there. Now, underlying all of this, Terry also has a lot of strengths that we would want to incorporate into treatment. He's intelligent and educated. He has material support from his family. He has this previous history of recovery. So just like Dr. Maloney mentioned, understanding what was helpful in that past recovery experience, being able to use some of those strengths and resilience factors again in treatment now. And he also has solid peer groups. He's well liked by other people, gets along with others well. That's going to be something that would be helpful, maybe even in developing new peer groups that might help promote recovery.
And so as we have this case conceptualization, one of the things we want to think about is what is the most appropriate level of care for Terry, right? What level of care does this individual need? And first we'll look at it through the substance use lens, and then we'll look at it through the eating disorder lens. So in the substance use arena, we have something called ASAM, or the American Society of Addiction Medicine, and we have the ASAM criteria, which helps to determine level of care. And in 2024, they switched from the 3rd edition to the 4th edition. And so as we can look here, right, and think about, first we have dimension 1, any withdrawal related to alcohol, right? And so we want to take that into consideration for Terry. Dimension 2, we want to think about any medical issues, right? Like, are there any metabolical issues, or, you know, any issues related to vital signs or anything like that that may impact Terry. You know, and one of the things for substance use, now this would not apply to Terry, that you want to take into consideration here is something called priority first. Many states for substance use in their regulations have priority first. So thinking about IV use or pregnancy, you would want to take into consideration. The third, we want to think about any suicidal ideation, self-harm, or harm to others, or any cognitive functioning impairments. As we know, Terry has had bouts of depression and has been diagnosed with major depressive disorder. Under Dimension 4, we want to consider all risks, whether that be medical complications, whether that be overdose risk, whether that be legal risk, or risk for victimization or exploitation. Under Dimension 5, we want to consider housing and family support. So Terry has family support, although he's unemployed. And then under Dimension 6, we want to think about any barriers to care, right? Is Terry willing to attend the recommended level of care? What is Terry's motivation? And again, how can we pull on that strengths and that resiliency, right? And so gathering all that information, bringing that together, we can look at it through a safety lens for what level of care does Terry need from that substance use perspective. And I'll turn it over to Nicole to look at it through the eating disorder lens.
Yeah, and luckily I think that these go pretty well together. When we're considering level of care for eating disorder treatment, we're generally relying on a couple different practice parameters, primarily the American Psychiatric Associations from 2023, but also the Society for Adolescent Health and Medicine has a position paper specifically related to medical management. Just like Dimension 2 of the ASAM, one of the things we want to consider with eating disorders as well is absolutely medical stabilization. And this is sort of a summary of from that medical assessment that we would want to do as part of our multidisciplinary assessment. If any of these criteria are being met, that would likely support and indicate a need for hospitalization either in a medical hospital or a specialized eating disorder unit to achieve medical stability from an eating disorder perspective, where we have vital signs stable, labs being more stable, weight being at a more safe level to be able to manage in a lower level of care, where there's just less risk of things like refeeding syndrome or something like that happening. So these are all things that we would look for and take into account. Now, barring that, if we go to the next slide, more on the APA practice guidelines, really similar to the ASAM, these are kind of about questions to consider. So using our clinical judgment, we want to think about recommending the least restrictive level of care that is going to be appropriate to treat the patient while considering these things. So we do want to consider medical stability, which we already talked about. We want to consider co-occurring conditions. If there are things like substance use that are going to affect treatment needs and may require a higher level of care, then that would push us in that direction. If a patient has already had a trial of outpatient treatment that was not successful, they didn't achieve kind of sustained recovery, then that would also likely lead us in the direction of a higher level of care. Thinking about to what extent the patient is able to control these behaviors, and that might be potentially a little difficult to assess, but based on our best judgment, if there's kind of no control present, then they may need to be in a much more structured environment that would be consistent with a higher level of care. We want to think about level of motivation to recover, insight, cooperation, willingness to participate in treatment. That might change our decision making there. And again, really similar to the ASAM, considering the psychosocial context. If the patient is in a setting where there's a high level of distress and they don't have much of a support system, again, that might point to a more structured environment, like a residential level of care. In Terry's case, he does have social supports and level of stress, some stressors, but not maybe not rising to the level where it's really going to impact his daily functioning. And then we also need to consider just logistical factors. So things like geography, what's available in the person's environment, in the person's geographical area. Are there financial or insurance concerns? Are there childcare needs? Or difficulties with transportation? In Terry's case, none of these would particularly present too much of a barrier, but certainly could if, for example, he was not on, didn't have insurance access or something like that because of his loss of his work and his employment that might be tied to that. So these will all be factors that we would want to consider from kind of an eating disorder lens. And again, fits kind of nicely together with the ASAM dimensions so that hopefully we can pull this all together into a plan that is going to make the most sense, both for addressing substance use and eating behaviors.
So as we think about Terry and our treatment planning here for him, so, Terry did attend detox for alcohol as we wanted to make sure he was safe there. And then following that, he was referred to a co-occurring partial hospitalization program or a day treatment program. And some interventions that were utilized as part of that case conceptualization included, psychoeducation, both on the substance use, his eating patterns, and the connections between the two of them. He participated in cognitive behavioral therapy sessions where he focused on establishing regular eating to break his cycle of restricting and binging. We also utilized behavioral activation for his depression. We incorporated nutritional counseling, including education on adequate variety and reestablishing hunger and fullness cues. We utilized motivational interviewing to really help him focus on, that ongoing engagement, attendance, right? Treatment only works if you attend. And so, Terry really struggled with his daily attendance at the day treatment program, right? Thinking, I got this, I can be discharged. I don't need to attend tomorrow. And so really utilizing motivational interviewing to help him identify his ongoing needs. We looked at skill building, particularly for emotional regulation and impulse control through DBT or dialectical behavioral therapy. And then we focused a lot on recovery maintenance planning. And here, really establishing awareness of Terry's triggers, utilizing personal intervention strategies and developing a relapse map to assist him in early intervention. And as we move on to the next section on interventions, we're going to dive deeper into recovery maintenance planning.
Perfect. Just taking a look at the time, we are running a little bit past where we wanted to be at this point, so we might go through these as efficiently as possible. We are going to talk about some evidence-based interventions. This is not going to be an exhaustive list by any means, but we wanted to highlight a couple of different interventions and considerations that we might be thinking about for when we're applying these strategies with co-occurring symptoms. So starting off with psychoeducation, something that we're often providing right at the start of treatment and then throughout treatment, right? One of the things that is a really key part of eating disorder treatment is psychoeducation about weight and weight changes that might be expected as part of treatment. Weight restoration is often a key treatment goal for patients with eating disorders where their weight has been suppressed, meaning that they have lost weight or they are their bodies are currently maintaining a weight that's below maybe where their body needs to be in order to function at its best and most optimal state. Now, kind of considering this from a couple different angles, when thinking of it from more of an eating disorder perspective, one thing that we might want to consider is that many times patients with eating disorders who are going through weight recovery really want to know what to expect, what to predict, how linear is their weight trajectory going to be? Is it going to feel kind of out of control to them? And one thing that I think about is that substance use adds another layer of impact on their metabolism, on their ability to absorb nutrients and their body composition that may make it a little bit more challenging for a team to exactly predict what's going to happen in weight restoration phase. So being able to discuss that and maybe also talk about the impact that their substance use, if they're continuing to engage in that, is having on their recovery and their ability to restore their body to a healthy place physically. On the other hand, as Dr. Maloney mentioned earlier, if we come at it more from a kind of substance use recovery angle, thinking about how weight gain might be really common in substance use recovery, and maybe providing some education and preemptive information there to help patients anticipate and expect that so they don't panic when their body starts to change, and really giving them the education on how their body has been probably undernourished in some ways. It's been impacted by the effect of the sugars and kind of the processing that has happened. And this might be a way that their body is attempting to reestablish homeostasis, or maybe trying to protect itself against those future states of famine when food is not being provided regularly to it. Now, I think either way, from the perspective, knowing that there is a high risk of eating disorders across the substance use population, and then, of course, when someone has an eating disorder, they are at high risk of engaging in those behaviors. Any psychoeducation that we're providing should be really cautious not to reinforce weight stigma or fear of weight gain, and instead really emphasizing the importance of stabilizing eating and substance use behaviors and tolerating or accepting weight and shape changes. I think sometimes we might rush to reassure that somebody that maybe changes are temporary, they're not going to last. And that might be true, but that also can run the risk of sort of over pathologizing or giving some reassurance where maybe that isn't where their body is going to end up after a course of recovery when it's achieved its kind of full healthy state. So just being cautious about sort of the language that we're using and what messages we're sending as providers with our education. Now, in Terry's case, he is not significantly underweight, but his weight is likely suppressed a bit due to years of skipping meals and really chaotic eating patterns. So we would want to support him in anticipating some weight recovery during treatment. And I think also helping then him be able to identify and catch any negative thoughts or feelings of body dissatisfaction that he may be starting to have, any urges that might be coming up to engage in weight control behaviors, and trying to catch and reduce those new ones before they start to kind of form a pattern and take hold from there.
All right, and as Nicole mentioned, we are running it slightly behind, so I'll go through some of these slides more quickly. And so one of the things with Terry was helping him to establish, urge surfing, to manage his urges, manage his cravings. And so we really talk about, mindfulness and how that can be helpful. And so we think about, a wave, riding the wave forward or playing the tape forward are common examples, particularly within 12-step communities. And in 12-step communities, this is especially helpful when they recommend calling a sponsor or a recovery coach, that distraction to help that urge or that craving subside. But really, the key here is normalizing cravings, right? Because sometimes those cravings can be extremely anxiety provoking for patients, and we want to normalize that as much as possible and help them think that they're not in relapsing just because they have a craving. And so as we look at the use of urge surfing, we also want to do cue exposure. Now, cue exposure is not indicated for substance use, right? I don't want to take Terry to the bar where he was drinking and expose him to that. However, that's not true as it relates to eating disorders. So we want to be able to provide exposure to some of those situations, people, food that may be associated with higher urges, and help Terry prevent engaging that behavior. And the literature evidence really has shown that this is effective for reducing binge eating, but not purging. And so, as we think about Terry, all of this information, the cue exposures, identifying his triggers, practicing his urge surfing along with other coping skills. All of this information was used to build a recovery maintenance plan for Terry. And so the recovery maintenance plan, even when people are highly motivated, engage in the highest quality eating disorder, substance use disorder treatment, there is a large portion of individuals who do relapse or have partial symptom remission. And we want to, again, normalize that to some degree and let them know that relapse can be common. And so to this, recovery maintenance planning is key. And so having that individual write down their triggers, their coping skills, the support system, right? And as Terry would go home in the evening following day treatment, what worked, what didn't work, right? We know that cravings can be so intense that having a physical recovery maintenance plan, knowing I'm going to do this when I experience it, and when my emotions are running high and panic sets in, can be extremely helpful, right? And then the last part here is exit planning. And exit planning is basically a story that is predetermined ahead of time of what an individual can say when they find themselves in a situation and need to leave immediately, right? Maybe their cravings are high, they're extremely fearful they're going to relapse. We have found that this is particularly helpful with adolescents. And so in short, the adolescents come up with sort of this little white lie, if you will. And it may be they're with friends who, are now drinking and they want to leave without relapsing. They can call mom, they can call dad, and they can tell this story, which whatever was created, so that mom and dad can come get them right away. And we've used this in family sessions so that everyone is on that same page and the parent can pick them up without question. And it's seen as a way to really build trust. And so now let's go back to Terry for a moment. So for Terry's recovery maintenance plan, right, looking at those triggers for substance use, restriction, and binge eating, again, identifying the coping skills he found useful. Who are those people in his network that promote his recovery? Any new peers or peer groups that he started? What lifestyle changes? And then also ongoing care and monitoring, right? What is he willing to do post-discharge, right? Who's he willing to see? How often is he willing to see? What does that journey look like for Terry?
Perfect. Well, we have caught up on our time and we're just where we wanted to be. So in our last about 12 minutes, we wanted to touch on some emerging or controversial topics that arise in the overlapping space in the eating disorder and substance use fields. And I just want to give the heads up that we're not planning on going in incredible depth about any of these topics, but more just wanted to make you aware of them because I think they are kind of hot topics. They're things that you might see or hear information about, and wanted to give you a little bit of signposting and some context for some of these discussions that you might see in the fields. So first, talking a little bit about harm reduction. Now, harm reduction is a term that we're using to describe interventions where our goal is to reduce the negative effects of behaviors without necessarily eliminating the problematic behaviors entirely. Now, there's very strong evidence, and Dr. Maloney is going to talk a little bit more about this, for the effectiveness of these approaches in the substance use field. Where it's more emerging is in the eating disorder field. Now, harm reduction is part of one treatment, so DBT, dialectical behavior therapy for bulimia nervosa and binge eating disorder, introduces a concept of dialectical abstinence that includes some harm reduction principles, and the idea being that lapses can happen and how do we minimize the harm associated with that lapse and then recommit to abstinence from there. Where it's more controversial, and I'll talk about this a little bit more in a couple of slides, is in the context of severe and enduring eating disorders or kind of more chronic presentations of eating disorders, especially anorexia nervosa.
All right, and as Nicole mentioned, harm reduction is, pretty well known and researched within the field of substance use. And again, it really, as she mentioned, are practical strategies used to reduce the negative consequence. This approach does not necessarily require abstinence, but focuses again on minimizing harm, improving health outcomes for individuals who continue to use substances. And so where we've seen a lot of this research, we saw this really in the 1980s as it applied to HIV and AIDS. We've seen it applied to hepatitis, and in the substance use world, we see it applied to overdose, right? Naloxone, became over the counter as truly an effort to spread harm reduction and reduce fatalities. With harm reduction, one of the key components throughout it is that individuals who are impacted have played a strong and critical role in the design of harm reduction programs, such as syringe exchange, naloxone distribution, and the first methadone program was started by an individual with a substance use disorder. And so with harm reduction, it really does take into account a lot of sociocultural features. It recognizes that there are realities of poverty, class, racism, social isolation, rural communities versus urban communities, LGBTQ communities, right? And so really those vulnerabilities, and really establishes that capacity for effectively dealing with the harms of substance use. And so in 2022, the National Council for Mental Wellbeing published a survey which outlined the priorities of patients seeking treatment. And at the core of this, harm reduction was found to really increase engagement and patients attending treatment and really following through with assignments and treatment direction. And so in this study, they found that the priorities of patients who entered treatment, their number one priority was staying alive, improving their quality of life, reducing their substance use, right? Being able to meet their basic needs, increasing their connection to their support system, whether that be their family, their job, improving their mental health, right? Nowhere in this list of the top 10 priorities was abstinence. And so this really does say a lot about what our patients are looking for, what their needs are, and how do we help them in their own recovery journey.
All right, and just to say a little bit more about some of the debates around harm reduction approaches, especially in the context, like I mentioned, of more severe and enduring eating disorders. I think one of the issues is that we don't even really have super great examples of what harm reduction would even look like in this population. Some of the things that might happen in a harm reduction approach could be something like collaborating with a patient on reaching or maintaining a lower weight than we would recommend for their body's optimum health. Another example could be focusing on enhancing quality of life versus symptom elimination and finding kind of where that line is. Now, the research is still emerging in this for sure. And some of the articles that have been published recently and kind of talks that are going on and things like that have I very much appreciate have involved the voices not only of clinicians, but also of people with lived experience. And some clinical and ethical concerns that both of those groups have raised. One is, as I just mentioned, there's really no research in this population for how effective that harm reduction approach is. So we don't really know exactly how to weigh those risks and benefits. It's a little bit unclear when we would use harm reduction and for who. Even if we tried to say, well, this could be used in the treatment of severe and enduring eating disorders, there's not even clear criteria for that. That's not an official diagnosis. It's kind of something that's been debated hotly as well in the literature. There's a lot of concern that harm reduction might ultimately aid and abet illness behavior. Oftentimes, these are pretty egosyntonic illnesses, and people absolutely may want to change some things, but their eating disorder really is kind of taking over a lot of their decision making as well. And so it becomes are we aiding and abetting the eating disorder instead of really supporting the patient's kind of true voice, and then who even gets to make that decision and that call. There's also one point, last point that I wanted to raise that's brought up by some folks with lived experience is, does this allow eating disorder clinicians and the field as a whole to kind of give up on striving to make better high quality treatments? If we kind of say, let's move towards harm reduction when, other treatments have failed, are we then kind of giving ourselves an out as a field to saying like, well, we don't need to continue focusing resources on how do we create high quality treatments? How do we make sure we're offering those high quality treatments? And how do we increase access to those high quality treatments? All right, another kind of hot topic or emerging area in the field related to food addiction. This often comes up when talking about eating disorders and substance use, because I think this is an area that a lot of times people will say, well, aren't eating disorders, can't you have like an addiction like you would to substances? And so again, this is not meant to be an in-depth talk about the research in this area, but wanted to give a couple minutes of describing what the kind of current state of the field is. So it is an emerging area of research, a lot of research looking at kind of animal and human neurobiological systems, how may foods and the way that foods are processed and the food ingredients that they include, how may those interact similarly or differently than other substances that we've talked about on those neurobiological systems. There are also researchers who focused on how do we even define this and have come up with behavior rating scales that are based on the substance use dependence criteria, but applying it to food and eating. There's been a particular focus on food addiction as it might relate to highly palatable foods or ultra processed foods. So really focusing on maybe there are certain kinds of foods or the ways that certain foods are prepared and processed that might make people more prone to these kind of addictive food behaviors. What the research is sort of demonstrating so far is that food addiction as a concept seems to overlap to some degree with binge eating disorder, with bulimia, and with obesity, but it doesn't fully overlap with any of those. And so researchers in this area have argued that that means that it is a different concept. It's something it's measuring something and kind of capturing something new and different than any of these other categories are. Now, when it comes to what would we do about food addiction if we agree that that is something that someone can experience? This is another area where research is still very much emerging on what those interventions would be and what the outcomes might be. There's been some focus on individual treatment approaches, including use of medication, surgeries, or lifestyle modification. There's also some implications for public health approaches. So, for example, if we believe that certain foods or ways that foods are processed leads to food addiction or has more of those properties, then that could imply a rationale for regulating food products, for example. And then I think lastly, this is a very wordy slide, so I'll try to summarize it quickly since I know we're about at the end of our time. I think that one of the really interesting points of controversy is if food addiction as a concept exists, what does that mean for the role of abstinence in treatment? Some researchers have suggested that if food addiction exists, that perhaps effective treatment might include abstinence from some of those foods. And where this gets tricky is that our kind of gold standard treatments in the eating disorder field tend to discourage what we call dietary restraint. So those attempts to avoid certain foods because they're considered forbidden or because we're fearful that it might lead to us, binge eating or feeling out of control. It's a really key part of CBTE in particular to address that dietary restraint. So again, this is sort of, there isn't really a key, this is the answer from this slide, but more just that there's ongoing kind of exploration of kind of which comes first in this process. So some people arguing that perhaps foods or food processes might actually prompt dietary restraint. And so again, abstinence from those foods might be indicated, whereas other people saying that dietary restraint leads to those kind of addictive, what can be perceived as addictive behaviors, binge eating, loss of control. So that is really the key thing that we need to target. So stay tuned on this one.
So another topic that we want to stay tuned on to see where the research takes us over the next several years. Many of us have heard or seen the ads on TV regarding GLP-1s, right? I don't know that you can turn on your television without seeing an ad for Ozempic or Wegovy or some of the compound medications, right? For substance use, preclinical studies have demonstrated that GLP-1 can reduce alcohol and substance intake as well as related behaviors by modulating the reward processing, stress, and cognitive functions, right? And so, you know, in some of the studies, particularly in animal studies, it has shown to decrease cocaine and heroin seeking behaviors. And so this has been very much an emerging research as an alternative for craving management within the substance use population. And so, you know, as we look to this, right, these have not been fully defined yet. The research is continually ongoing. Again, somewhat moved from preclinical to clinical trials now. Nora Volkov is spearheading some of these studies, which have been limited. And, you know, some of their studies have been less conclusive. However, most support the safety and potential efficacy of the GLP-1s in substance use treatment.
So while there's all this promise and sort of exciting possibility for use of these medications to potentially really help with managing some of those cravings and being able to help in that area in the eating disorder world, also some folks with some excitement for similar things related to eating behaviors, especially binge eating disorder and bulimia, but I think also a lot of concern. And just to really quickly summarize, I think some of the biggest concerns that tend to come up are, is this going to, that this drug has the potential for misuse as a new form of a diet drug, right? Because it does reduce appetite, reduces this kind of food noise or thinking about food, increases satiation. So very easily could turn into a way to restrict eating very easily. It's also the use of this medication without appropriate screening for eating disorder symptoms. And I think this is especially a concern for people in higher weight bodies, where people, due to kind of stigma and stereotypes, may think, oh, well, these folks couldn't possibly have an eating disorder, so they're not appropriately screened for that and may be given these medications without considering the potential risks that might be at play for them. And then again, potential conflict within treatment. If someone comes into treatment for an eating disorder on a GLP-1 agonist, how is that going to interact with the kind of eating disorders treatment strategies that we have that tend to focus on trying to reduce weight control behaviors, increase regular eating, and so forth. So stay tuned on that one. And that takes us to the end of our information part of our presentation.
So much, Dr. Stetler and Dr. Maloney. That was fantastic. I'm so happy that we got to the GLP-1s because there were a couple of questions about that piece specifically. So now we are going to jump into our Q&A section. Please, if you have a question, you can submit that at the Q&A section on your taskbar. We'll try to answer as many questions as we can with the time left. I'm going to combine several questions together that are similar. If we don't get to your question, feel free to send us an email afterwards to webinars@rogersvh.org, and we'll make sure to follow up with you. So jumping back to the beginning around drunkorexia, we know that it's not a DSM-defined disorder. What would you suggest diagnostically? Would it be diagnosed as alcohol use disorder, anorexia? How would you kind of diagnostically tease that out?
Not sure, Dr. Maloney, if you have thoughts. I think my thoughts would be that to use the diagnoses we have, and it may be that someone meets criteria for both an alcohol use disorder and an eating disorder. And from an eating disorder perspective, I would give the diagnosis that most closely matches. So for example, if there's a lot of restrictive eating and there's significant weight loss, I might give a diagnosis of anorexia. If there is not really weight loss and there's a lot of other compensatory behaviors, as we talked about, goes along with drunkorexia, then I might think about something like bulimia nervosa. Or if someone isn't really fitting any criteria for one of the kind of those eating disorders, I might think about something like an other specified.
Yeah, I agree with that. Really, utilizing the diagnosis that we do have available to us. In practice, when I've seen this, there's been anxiety disorders that tend to go along with it as well. And so, thinking about the eating disorder diagnosis, what's appropriate, the substance use disorder, what's appropriate, and then possibly even a mood disorder might be appropriate as well.
Thank you. And just a follow-up, there were just a couple of comments around the term drunkorexia and how does that feel regarding like sensitivity towards the patient and what they're experiencing? Do you all have any thoughts around just that term in general?
Well, one of my passions is stigma. And so, yes, that word sort of hits me in the gut. And I think about, we're really trying, in the presentation, we talked about recovery maintenance versus relapse prevention. Same thing, but it comes from that positive perspective. So the drunkorexia certainly hits me in the gut. And if you go to research this topic, that's what you're going to find. So again, if you're interested in it, that is the terminology being used within research. Nicole, I don't know if you have any differing opinion or same.
No, I think very similarly. The other thing that I think about is I think it's a term that sometimes our patients know about and come into treatment knowing about as well, because it sometimes shows up in kind of popular cultural media in that way. And so that there's risks and benefits, but I think if it's a term that people are familiar with, I may not choose to use that term with a patient that I'm working with. Absolutely. If it's not their language, I'm not going to say, oh, you have drunkorexia. That would not be very helpful. But again, if you're looking for your own research to be able to inform treatment, or if someone is coming to me and saying, oh, I write about this thing and I think that that's kind of what's going on for me, then I might want to utilize that term since it's kind of within their language and then helps them be able to connect it to information that they have.
Yeah. Next question around what do you do if an eating disorder and substance use continuously alternate in severity throughout the treatment progress? And how do you pick which one to focus on first, or what does that look like?
I think it's important for us, first I always look at safety, right? If they're, severely underweight, do we need to look at refeeding? Or if it's the substance use and they're going through withdrawals or DTs, right? So we need to medicate for that. I tend to look at safety first, but I think really gold standard is concurrent treatment. How does one feed off another without being I was going to say pun, but I don't know that that's the right word. But how do they interact with one another? How can we address them simultaneously? And again, the key here, I think, is multidisciplinary treatment team, right? Can we have experts that are really coming together to support that patient? But first and foremost is safety.
Yeah, I agree. I think that that's a good way of prioritizing things. Safety, both from the substance use and the eating disorder side, those are both going to, whatever that is going to take priority. And then I think going back to what we talked about with the case conceptualization, to me, if symptoms or severity is kind of alternating back and forth, that suggests to me that there are some shared underlying maintenance factors, some functions of those behaviors that are maintaining both. And so how can we more fully understand what those are and be able to address those in treatment so that we're not just playing whack-a-mole and trying to reduce one and then the other kind of pops up or gets worse.
Thank you. And going back to the case study with Terry, a question around, in that assessment period, was trauma history explored and assessed for this specific individual? And did that apply at
Yes,
all?
yes. Every patient really gets at least in our practice, every patient gets a trauma history, which, goes into the case conceptualization and, what do we need to take into account, and really those socio-cultural, factors, right? What from Terry's life, his previous history, his current history, what do we need to take into account there? Because we also know that another risk factor can be LGBTQ, right? We have quite a few individuals that identify in that area, and we want to be sensitive, and we want to be able to provide trauma-informed care.
I think we have time for one more question. A lot came through at the end here, so forgive me trying to sift through, but one question is around, where does intentional pursuit of weight loss come into play for clients who are having a disordered eating behavior, substance abuse concerns?
Could you repeat the question really quickly, Genevieve?
Yes. Where does the intentional pursuit of weight loss come into play for clients who are having disordered eating behavior as well as substance use concerns? There's also a comment around, what are your thoughts in the health at every size approach to treatment?
Yeah, my brain is kind of going in a couple different tracks. So I think from an eating disorder perspective, health at every size approach, and for folks who maybe are not as familiar with that, it's essentially, there's a lot of history to it. I encourage you to read more, but my quick, in a nutshell, statement about it would be, it's a kind of a public health and framework and understanding that we do not need to pursue weight loss in order to achieve health or health outcomes that someone is interested in. And there are a lot of other social determinants of health that we ignore when we focus specifically on weight and weight loss. So many, I would say, that it is certainly the predominant paradigm in the eating disorder field right now to embrace a health at every size approach, and to consider that eating disorder treatment should be applied based off of symptoms and behaviors, and not based off of someone's weight and where they're at. So for example, if I wouldn't encourage someone at a particular body size to lose weight, then I shouldn't be encouraging someone at a different body size to lose weight as part of an eating disorder treatment. So that's kind of that piece of it. I think the question about the intentional pursuit of intentional weight loss is throwing me off a little bit. I mean, I think certainly that is, I guess I'm not understanding if the question is more about, is there a place for someone to intentionally pursue to lose weight in the course of treatment? Or, because certainly that is a symptom, right, of many eating disorders, is that people are intending to lose weight. So just not sure if I'm understanding if it's, do we include that or incorporate that as part of treatment or not?
I don't know the answer to that question. And so I think, given the time, that we'll go ahead and wrap there. Then if that individual who submitted the question, you can absolutely reach out to further clarify at webinars@rogersbh.org. So that is all the time for our questions. Note that we do have this recording, and it will be available to you all on Rogers YouTube website here in the next couple of days, as well as our resources page through Rogers website as well. And before we conclude, if you could share just a few key takeaways from the wonderful presentation today.
Certainly, Genevieve. So on behalf of Dr. Stetler and I, the 3 key points that we hope you take away from today. One, it is essential to complete a thorough assessment to understand the patient's motivation, level of care, and current needs to address a comprehensive approach to treatment. The second, conceptualization of the functions of both the eating disorder and the substance use disorder symptom can help guide coordinated efforts, interventions, and address overlapping and distinct maintaining mechanisms. And then lastly, and you've probably heard me say this a couple of times now, you know, a multidisciplinary team is vital. You know, from medical to nursing to clinical to lived experience, right? Having recovery coaches. You know, teams really need to hold a patient-centered focus while maintaining both safety and engagement.
Thank you very much. And thank you again, Dr. Maloney and Dr. Stetler, for that wonderful presentation. And so within the next 30 minutes, you will receive an email link to your personal CE-Go dashboard. You will be able to access the PDFs of the PowerPoint today, as well as the full list of references. For those of you who met the required time commitment and are eligible for your CE credits, you will also use that link to complete the evaluation on our webinar today, and you can download your CE certificate on your dashboard as well at any time. If you have any questions regarding that email, please contact support@ce-go.com. Our community liaisons are looking forward to connecting with you about your practice and what you're experiencing in the community, as well as to share the treatment options available to your patients here at Rogers. And again, thank you so much for spending your morning or your afternoon with us. And we hope that you have a fantastic day, and we look forward to connecting with you. Thank you, everyone.